Just a bit of background on why I ended up working on this. It wasn't an area I had ever intended to work on. I work in the central unit of the World Bank, the Central Health Department, and one of the things that you do if you work in the department is to review projects that are under preparation in different countries. To sort of take a second look, does the project make sense? And I was reviewing a project for Nigeria, and one of the main goals of the project was to reduce child mortality in Nigeria, which was much higher than it should be. And they had sort of a plan for addressing this problem in the project, which was to be implemented exclusively within the public sector. And at that point, I had all the sort of demographic and health surveys right in front of me. I looked at the data for Nigeria, and I said, well, okay, that's going to reach somewhere between 20 and 30% of the children in Nigeria who go to the public sector. But don't you think you need something in your project to maybe reach the other 70%? And basically the answer was no. This is, we have a standard protocol. We have a program that we use to reduce child mortality in developing countries, and this is, globally accepted. We all agree it's the right thing to do so. And the project, passed despite my complete mystification. So I ended up working on this, what I'm going to present now with, it's the work of myself and two other people. And that is Flavio Bustreo, who's now at the World Health Organization, and Henrik Axelsson, who's at the Partnership for Maternal, Newborn, and Child Health. Very quickly, we're going to talk about child mortality, where are children dying, child health programs, where sick children are treated. I've already given you a bit of a hint of what the answer to that one is, some strategies, and then open it up to discuss what it means, because I don't think I have all the answers to that one. Where it's 10 million child deaths that are occurring every year. This is the location. The dots represent 5,000 child deaths. The two regions where the most children are dying every year is Sub-Saharan Africa, I think it's about 41%, and South Asia is 32%. The third region is East Asia. So that's, what are they dying of? Still, the predominant killers of children is simple things: pneumonia, diarrhea, malaria, which accounts for more than 50% of child deaths, with undernutrition as an underlying cause. And probably many of you know that we have very simple things that we could do to prevent these deaths. And if these very simple interventions were implemented, 6 million of these deaths could be avoided. So this child health program that I already mentioned, it's called the Integrated Management of Childhood Illness. This, by the way, this is what everyone does. This is not, it's a World Health Organization, and UNICEF developed the protocol for it, but it is accepted as the sort of main program designed for reducing child mortality. It has three components: training frontline public health workers to do the right thing when they see children that are sick with these things that they're dying of: malaria, pneumonia, diarrheal diseases. Strengthening the supervision in the frontline public clinics also, which includes both supervision of staff, but also ensuring access to the drugs that are needed. And also community outreach from the public clinics into the communities to do both health education out in the communities, and also to get people to bring their children to the clinics when they're sick. And there is evidence that when this is well implemented, this program does improve the treatment and the outcomes for the sick children who are brought to the public clinics. But where are the sick children actually being taken? Now, I mentioned that the two regions where most of the deaths are concentrated is Sub-Saharan. Do we have a pointer?
Yeah.
All right. Sub-Saharan Africa, about 50%. This is split, about 50%. Again, of course, countries vary, but this is an average for the region. About 50% of sick children to public, 50% to the private. And then South Asia, the second most, with the second largest number of children are dying. We see about 80% of sick children going to the private sector. This is from DHS surveys since 2000. So, as I've already said, the child health programs which don't engage the private sector in some way are probably not going to be able to achieve population level reductions in mortality. This is what I said to the task manager for the project in Nigeria, and what she said was, no, but you understand, we're going to improve the services in the public sector, and then, you know, basically people will switch. They'll stop going to the private sector, which we know has all these problems, and they'll switch. But basically, the elasticity that we see with respect to quality improvement is actually quite low. That's, you know, worth the whole conversation right there, but as we observe it, it just doesn't seem to happen. So, as I said, the private sector is really large, but what I'm not saying, in fact, the first presentation already has alluded to the fact that private sector it's the choice of people, but that doesn't mean that it's good. It's just with respect to child health, we know that they don't do the right things for children with diarrhea. The best thing to do would be to give them oral rehydration, but instead they might give them antibiotics. They may give them several medications if they can, because maybe they don't know better. Maybe a medical representative helped them understand that this is the right thing to do. And this is across the board. Malaria treatment, also lots and lots of problems with malaria treatment, which, as we know, especially in sub-Saharan Africa, is a very big killer of children. So the other thing that the task manager for Nigeria said, well, okay, the private sector is large. Maybe not everybody's going to switch, but we really don't have any evidence. We don't know. We don't know what one could do working with the private sector. So I really, there's no way that I can include something like that in my project. Well, that is a question. What could we do with the relevant private providers for sick children? What evidence for the strategies? What evidence is there for the strategies to engage the private sector? And this is going to be a very quick skim over it. I have the PowerPoint, I'm happy to share it, and there's a working paper which has much more information. So forgive me for flying over. These are the 5 strategies that look the most promising with respect to child health programs. Contracting, as you know, contracting for the provision from private providers, which gives the paying entity much more control over the package of services. Obviously, you can get rid of out-of-pocket payments as well, and you have leverage over quality. Training plus, which I'm going to talk about what that is in a moment. Insurance subsidies is another strategy that's been used. Not sure what to call this, but the upstream or factor gate subsidy. This I'm referring to what's being done under the affordable medicines facility for malaria right now, which early days, but looks like it might have something to do to help with the private sector in malaria, and vouchers. So again, flying quickly through contracting, there's a growing amount of evidence that it can work, both obviously in developed countries, but also increasingly in developing countries, with stronger evidence around primary health care packages, contracting for packages, both urban and rural areas, nutrition services also, and for district hospital services. Training plus, what do I mean by training plus? Training by itself tends to not change behavior very much, neither in the public sector nor in the private sector. But there's growing evidence that if you train various types of providers and you complement it with subsidized access to drug supply, establishment of referral relations, strengthened regulatory oversight, or other sorts of incentives, then you can see sustained behavior changes on the part of the private providers, which could lead to better drug dispensing, better treatment of sick children. Insurance subsidies has worked it's obviously used extensively in developed countries, but in developing countries, it's really just the beginning of understanding, what are the possibilities there. In fact, if there are going to be any tough questions about that, we'll ask David Dorr, who knows 100 times more than anybody else I know about this. But there is some emerging evidence that if you define a package of core services that can really make a difference for sick children, and you give a subsidy to cover low-income populations. Assuming you have an insurance system, that it can lead to higher utilization, and that there's some proxy indicators showing better results for child mortality. Okay, I'm not going to go. It's too complicated to go into the AMFM, which is basically a way of putting a subsidy at the from the drug companies to get the artemisinin combination therapy drugs that are the most effective drugs for malaria into the private sector delivery system. It's being piloted now. Kara Hansen is at this conference, and if you're interested in this, I encourage you to talk to her. It's a very, if we could make a difference on private sector treatment for malaria in sub-Saharan Africa, a lot of those dots that you saw on that first map could go away. So it's certainly something we should all be watching with great interest, and I am. Vouchers, they are used in developed countries for various things. That you can use them for specific products or specific services, and there is some limited evidence confirming that they can be used in particular for insecticide-treated bed nets, and they've also been used for delivery attendances to increase women having her delivery with a skilled attendant. Yes. So obviously, lots more to talk about. Love to have questions, but here's the things that come to my mind. Obviously, in this audience, I want to emphasize that there's much more research needed on the interventions and the program designs to engage the private sector toward child health, and that. But at the same time, I think we have to acknowledge that the current programs that are using only public sector strengthening as their main strategy really, are not going to achieve population level impacts. They're going to, frankly, they're going to not reach a lot of the children we're trying to help. And then, as a sort of pondering question, a lot of this evidence has been around for quite some time, and I still find it, frankly, kind of surprising that the programs, in many instances, continue to exclude the sort of engagement of the private sector when we sort of know that really it's not going to get us where we're trying to go with respect to reducing child deaths.